Pediatric Medical Emergencies Part 2. In this discussion, we're going to talk about a handful of GI emergencies and a couple of different endocrine emergencies that you need to watch out for in the pediatric population. So let's start off with the GI emergencies. These are disorders specifically involving the anatomy of the gastrointestinal system. So we'll start off with a couple of symptoms more than diseases, but vomiting and diarrhea, and then we will talk about intussusception and appendicitis. So let's start with nausea and vomiting. So technically, like I just said, nausea and vomiting, it's not a disease, but it's a collection of symptoms that are peripheral and secondary to other disease processes. Common causes of nausea and vomiting include fever, ear infections, respiratory infections, really any kind of infection that can invade your system and cause a response. So risks of nausea and vomiting, the most important one specifically is dehydration because it can lead to a lot of the other ones that we're about to discuss. Acidosis, hypoglycemia, anorexia, and electrolyte imbalances that will potentially lead to fatal arrhythmias. So another big risk of nausea and vomiting is the risk of aspiration. If a child breathes in some of these particulates of the gastrointestinal system, or the byproducts of the breakdown of food and all the gastric acids and components thereof, and you breathe that into your lungs, that can typically lead to pneumonia. So you can have aspirational pneumonia, and that's not good. Then you're dealing with a whole different set of symptoms, and you have a pediatric that is at risk of sepsis. So the treatment: maintaining ABCs. That's what we're always starting off with. We are maintaining a patent airway, assisting in with ventilations as needed with supplemental oxygen. You may just need a non-rebreather at this point, but end all be all is make sure that airway is patent. You're preventing any type of risk of aspiration. Circulation, here we're talking about the need for intravenous access in order to correct the dehydration and the electrolyte imbalances that we were discussing that may potentially lead to arrhythmias. So if you have signs of shock, you want to go ahead and initiate fluids at 20 milliliters per kilogram if the patient is greater than 30 days old. If the patient is less than 30 days old, we will use our neonatal bolus, which will be 10 milliliters per kilogram. So for vomiting that persists, you can consider ondansetron or Zofran at 0.1 milligrams per kilogram, PO, IM, or IV, or Phenergan, also known as promethazine. The dose for this is going to be 0.25 to 0.5 milligrams per kilogram, PO, IV, or intramuscular. Now keep in mind that Phenergan is contraindicated for patients that are less than 2 years old. So let's move on to diarrhea. Diarrhea is a common occurrence during development, and it is a common illness, but we are describing diarrhea when we say that the patient has had 10 or more stools per day. So you need to be asking the parents, the caregivers, the teachers, whoever the caregiver is, if the patient has had 10 or more messy diapers per day. And you can ask questions about consistency, color, so on and so forth. Now, risks from diarrhea include dehydration leading to electrolyte imbalances similar to nausea and vomiting. And it can also cause arrhythmias or dysrhythmias, just like the electrolyte imbalances from vomiting. Also, the patient is at risk for anorexia because they won't feel like they want to eat, and an increase in potential abdominal pain. Now, something else with diarrhea is that the skin around the buttocks will be at potential for irritation due to the gastric acids, which can cause a rash if not cleaned adequately or frequently enough. So the treatment of diarrhea is going to be very similar to that of nausea and vomiting. So we want to secure ABCs, like we said before, assisting with correcting the hypoxia and initiating vascular access so that we can administer our fluid bolus to treat for dehydration. Also in this situation, if it's an infant, you do want to make sure that the infant has a new, clean, dry diaper, that their bottom is dry, and that you can potentially apply some Aquaphor or some other soothing balm to treat the affected skin to kind of decrease the pain for the child. So back to the fluid boluses, we want to administer 20 mLs per kg of normal saline or lactated ringers for children that are greater than 30 days old. And now remember, for the neonatal population, That bolus changes to 10 milliliters per kilogram. So let's move on. Let's talk about something called intussusception. All right, so this is a process in which a bowel or a segment of the bowel becomes telescoped into the adjoining segment of the bowel. So ultimately, this causes a few things. First off, this causes a bowel obstruction. Second off, this can potentially cause a complete cutoff in circulation to that segment of the bowel, which can result in necrosis and infarction, which can lead to a systemic infection and sepsis and potential intestinal gangrene. So this is a very common cause in abdominal pain in the patient population that is less than a year old. So we are talking about infants here. So something else that's interesting is that this is a larger cause for surgical emergencies in children. So 25% of abdominal surgical emergencies in children that are less than 5 years old. So that accounts for more than appendicitis, which we're about to talk about. But that's very interesting because, and that is the reason why I think this is very pertinent to your education and why you need to know about it. Doesn't really talk about it much in your book. So if you want to do a little more research, you can online. So the pain in intussusception is very colicky, it's severe, and it's intermittent, meaning that it comes and goes. It goes away, and then it'll come back. So parents describe the child during your history taking as maybe they will draw their legs in up toward their abdomen, and then they'll start kicking their legs up in the air. So this is the child's attempt to dislodge what they feel in that they have a bowel that is stuck. So in between the attacks, the child appears to be calm, collected, and relieved. So now let's talk about the signs and symptoms. Vomiting, because again, it's backed up. If you have an obstruction, nothing's going to be able to pass here. Abdominal pain and potentially passage of blood per rectum. And I'll show you a picture of, there's a very specific description of the blood that's going to be coming out, and it's called current jelly appearance. And I'll show you a picture here in a second. But abdominal distension is frequently found if the obstruction is complete. Now, if an intestinal gangrene and infarction have occurred, peritonitis may be suggestive, just because of the basis of sepsis and rigidity and involuntary guarding. So keep that in mind too, that you may have a septic patient with this illness. So a picture's worth 1,000 words. So take a look here. If you look at the small illustration at the top, and again, this is found on mayoclinic.org. You can follow the link here if you want to take a look at it and read more about it. But the small intestine with intussusception is illustrated here. Notice that a piece of the mesentery is actually pulled inside the larger telescoped part. So the problem with that is that the mesentery contains all of the blood vessels, and it also provides support and keeping all of the intestines together. So the fact that it actually has the blood vessels, or it carries and it secures the blood vessels that supply oxygen to the intestines. So it's being cut off here. And you can look at the larger illustration down below to where you see that inside the telescoped part, you have blood vessels within the mesentery that are pinched off. So that's going to lead to potential anaerobic metabolism, which can cause necrosis, which can cause gangrene, also can cause sepsis, which can kill the patient. So that is why this is a surgical emergency. So something that I do want to discuss is the actual appearance of the vomit, and that's why it's important to ask questions about the appearance of the discharges from the pediatric patient. Maybe you can actually ask to see the vomit. So initially, prior to obstruction or early stages in the obstruction, the vomit will appear to be non-bilious. But however, after the obstruction is complete, or as it's approaching a complete obstruction and the child's no longer being able to eat, it can have this bright green bilious appearance. So take a look at this picture here and you'll be able to see what I'm talking about. Now, the last thing I wanted to discuss was that current jelly appearance to the stool that I was talking about earlier. So it has this current jelly appearance due to it being a mixture of mucus, sloughed intestinal mucosa, and blood that's been shed. So keep that in mind. You can take a look at their diapers and see if that's what it looks like. Now let's talk about appendicitis for a moment. Appendicitis is acute inflammation and infection of the appendix. It's a frequent condition, or it's a condition that frequently leads to emergent abdominal surgery in children. But as we talked about in the last discussion over intussusception, it comes second to that. So in children under the ages of 5. So signs and symptoms of this include fever, vomiting, anorexia, and a vague periumbilical pain. So when we talk about periumbilical, what are we saying? We're saying pain around the area of the belly button. So that is followed by a migration of the pain to the right lower quadrant. So it can be a radiation of the pain that initiates periumbilically that radiates down to the right lower quadrant. But essentially, as the disease process worsens, you will have an increase of fever and of vomiting. Now, here's the thing to keep in mind. If the appendix does perforate, then the patient will have an interval of pain relief. So that should actually kind of heighten your senses to an increase in acuity and an increase of your need to transport rapidly. So if the appendix perforates, it's an interval that you will have the patient will experience an interval of pain relief followed by the development of generalized abdominal pain leading to peritonitis, severe abdominal pain, diffuse. So treatment of this: airway, breathing, and circulation maintenance, IV access, potentially bilaterally if you can, intravenous fluid administration, and pain management via morphine or fentanyl if the patient can tolerate, if their hemodynamic status can tolerate. And antiemetic medication should be administered. So if you go back to the vomiting section of this presentation where I talked about ondansetron or Phenergan, whichever one you have. So I want to talk about one assessment tool, McBurney Point. So this is how you can tell if it truly is appendicitis or not. So McBurney Point, and typically McBurney Point is even more highlighted during perforation of the appendix. But if you take the umbilicus and you draw a straight line down to just above the iliac area, or just above, like to the right of the suprapubic area as well. So if you have the iliac area, if you cut it in half between the iliac and the umbilicus on the right lower quadrant, that is where McBurney Point can be found, and it's a point of maximal tenderness. Also, if the appendix is perforated, you'll have like a golf ball or a mass, so to speak, in that area. So that's something to keep in mind. Now let's talk about the endocrine emergencies involved with the pediatric population. I want to discuss two primary ones. So when we talk about endocrine emergencies, we're talking about disorders that involve endocrine glands which send messages via the secretion of hormones. And it involves the maintenance of metabolism. So let's start off with hypoglycemia. Hypoglycemia is described characteristically as abnormally low concentration of glucose in the blood. So it's a true medical emergency that needs treatment immediately if it hits all the parameters. So let's talk about two patient populations that are at a high risk of hypoglycemia. First off, diabetic patients. So they are at risk whenever they have strenuous exercise, there's too much insulin given, if they have something severe like meningitis, pneumonia, or any other type of illness that may cause significant dehydration. Also, let's talk about non-diabetic patients and when they are at risk. If they have an increase in physical activity, or if they're playing too hard, if they have diet changes such as anorexia, if they have any severe illness that has caused fever, which will increase metabolic demand, or if they are growing, if they are experiencing a period of growth over a couple of weeks to months, then it's hard for their body to keep up. So signs and symptoms definitely includes a change in mental status, potential tachycardia, cool and diaphoretic skin, and a low blood sugar, obviously, a low glucose level, a low blood glucose level, and potentially coma. So when I say coma, I'm talking about they're not even responsive to pain. They're not responsive to verbal, so this patient will be unresponsive. Now, treatment. You initiate glucose treatment if the blood glucose level is less than 70 milligrams per deciliter. Okay, so if they're rocking around 80 or 90, likely they're still going to be alert enough to where you can give them some juice, some Gatorade, Pedialyte, whatever you have that has some glucose in it that will bring up the blood sugar. So if it is below 70 and they're experiencing symptoms to where they cannot, if they are altered enough to where they cannot maintain their airway, that is when you administer IV dextrose. And we will talk in the next slide about how you separate those age groups. So obviously, first off, we want to secure ABCs. Airway, breathing, and circulation, make sure it's intact. Initiate IV access, and you want to start initiating IV fluids, and you can dilute your dextrose with the fluids. All right. So if the patient has an altered mental status, you can administer D25 or D10 via the IV, or you can administer intramuscular glucagon. So let's look at the treatments and the different dosing regimens of these different medications. So starting off, glucagon, you can administer 0.02 to 0.03 milligrams per kilogram intramuscularly with a max of 1 milligram for hypoglycemia. So that's going to be a little more emergent. You can't get a line. You have to resort to glucagon. Dextrose. So overall, you're going to be giving 0.5 to 1 gram per kilogram IV. But let's narrow that down a little bit. All right. So for neonates, for patients that are less than 30 days old, we want to utilize D10. Okay. If you don't carry D10, how do you make it? Well, one way is that you could take your syringe of D50, you can push out 40 milliliters and draw up 40 milliliters of normal saline. And that will be a 4-to-1 normal saline to D50 concentration. All right. And you can apply that principle to D25 as well. So your dose of D10 for a neonate is going to be 2 milliliters per kilogram. So get the child's weight, do the math, and multiply that by 2. All right. You get the child's weight in pounds, divide by 2.2, and multiply that by 2. And that's how many milliliters of D10 you want to administer. Apply that principle for patients that are 30 days old to 2 years old. So in between that gap, we want to administer D25, and we want to administer 2 milliliters per kilogram of D25 to that patient. Now, if the patient is over 2 years old, you administer the same dose that you would to an adult patient, which is 1 milliliter per kilogram of D50. All right. Up to, obviously, 25 grams. And you want to reassess at that point. So let's talk about hyperglycemia. This is an abnormally high concentration of glucose in the bloodstream. This is a danger because this can cause increased urination, which can cause dehydration. So let's talk about that for a minute. So hyperglycemia and diabetic ketoacidosis are the most common findings in new onset diabetics. So with that being said, they didn't know they were diabetic, and so it kind of got out of hand, and now they are in a diabetic emergency. Hyperglycemia is commonly associated with too much food relative to injected insulin or in retrospect to body activity. Missing insulin injections is also related to hyperglycemia, as well as defective insulin pumps. Also, illnesses or stress can cause hyperglycemia as well. So signs and symptoms. So the patient may actually have a history of diabetes, but classically in hyperglycemic patients who are in diabetic ketoacidosis have fruity breath odors, altered level of consciousness, warm and dry skin, and potentially are dehydrated. And that is because of polyuria. So polyuria, they have increased in their diuresis due to gradients within the bloodstream that are actually causing more urine to be expelled. That will lead to polydipsia. So they are thirsty. They appear that, or they feel like, hey, I'm dehydrated, so I need to drink more. So polydipsia is caused from polyuria. Now, since we have an abnormal amount of blood being circulated throughout the bloodstream, the patient's going to feel hungry. So they're going to feel like they need to eat more. So polyphagia. Why do they feel like they need to eat more? Well, because the cells are not utilizing the glucose that's floating around in the blood. So that's why you have the 3 P's of hyperglycemia, which are polyuria, polydipsia, and polyphagia. All right. So treatment of this. We want to, obviously, first and foremost, secure the ABCs. Then we want to get the vital signs and apply them on the EKG. Then assess their blood glucose level and administer IV fluids to try to correct the dehydration, which can potentially lead to arrhythmias. All right, so that's it for this one. Thanks for watching. And what's next? So you need to go ahead and tune in to Pediatric Medical Emergencies Part 3, where we talk about toxicology, SIDS, and something called ALTE. If you have any questions, shoot me an email at the address found below, and we'll see you then.